Welcome, everyone. This is our second Conversations with Dr. Tony, and it really is my pleasure to have really a very distinguished scientist and clinician to share with us one of the areas that so many practitioners in mental health services, particularly with children's services, addressing the issue related to evidence-based practices. Let me just tell you a little bit about our distinguished guest today. Kimberly Hoagwood is a professor of child and adolescent psychiatry and the vice chair for research in the Department of Child and Adolescent Psychiatry at the New York University School of Medicine. She also works at the Division of Children, Youth, and Families at the New York State Office of Mental Health. In that role, she's a research scientist and has really promoted changes within our healthcare system. Previously, she was a professor of clinical psychology and psychiatry at Columbia, specializing in children's mental health services research. But before coming to New York, she was the Associate Director for Child and Adolescent Mental Health Research with the National Institute of Mental Health. And she oversaw the portfolio of research on child and adolescent mental health, from very basic research to applied science. This gave her a broad perspective on research gaps and on ways to connect different areas of science through interdisciplinary theory and methods. She served as a scientific editor for the Office of the Surgeon General's National Agenda on Children's Mental Health with Dr. David Satcher. She's director of the Center for Implementation Dissemination of Evidence-Based Practices among States, known as the IDEAS Center, an advanced center that's funded by the National Institute of Mental Health. She's been involved in numerous grants and many national committees. She's currently a member of the National Academy of Science, Engineering, and Medicine Forum on Children's Cognitive, Affective, and Behavioral Health. Her particular research emphasis is on parent activation in children's health services, quality measurement in children's behavioral health, and improving state policy making via implementation of research-informed policies affecting child and family services. We are really very, very fortunate to have Dr. Hoagwood with us today. So thanks very much, Dr. Hoagwood, for joining us. One of the first questions I always ask everyone is that, you've decided to really focus your career and contribute to this area of children's mental health services. Why did you choose that? You could have done many, many different things. Why was that area so important to you?
Well, I think there were a lot of reasons and a lot of things that happened in my life personally and professionally. I think I got started with it because I raised my two brothers. So I'm an older sister, had one brother 2 years younger than myself, one brother 12 years younger than myself. And for various reasons, when I was 14, I sort of took over as head of the household. And I had not a clue about what I was doing, and nor did many people, actually. So I think I sort of got it in my blood to pay attention to kids and how they learn, how they think, what they need. So I think some of it just started back then. The other thing that happened, a couple of things. One was that I wasn't sure what to do. I was an English major, and it was my mother-in-law who said, direct service with kids. You got a knack with kids. Take a child psychology class. And this was after I already had my bachelor's degree. So I went back and did that, and I just loved it. I just loved it for whatever reason. It was a wonderful class. And then there was a particular moment in time, and I remember just where I was standing, where Bob Friedman's System of Care work in Tampa, those conferences were starting, and I was reading the newsletters from that. And I had then had a chance to, I'd gotten my degree, and I'd had a chance to work in all the different systems. And it all came together for me at a particular moment in time saying, this is what I want to do. It's the system research, it's the services research for kids and families, and what is happening here in Tampa is setting the stage for the country, and I want to be part of it.
Great.
So it was sort of lots of different things.
Wow. Yeah. And in a way, I kind of think of you as having sort of the historian of what's been happening in mental health services and research. So can you just say a little bit about how you think things have sort of evolved over the last decades in this whole area?
Boy, big question. They've changed in some ways a lot, and in some ways very little. So the whole movement, so to speak, in services research in children and advocacy and the science came about in the mid-'80s. Jane Nitzer's book, unclaimed children sort of set things in motion. And then you had Bob Friedman and Beth Stroll's System of Care monograph, which set some of those principles. And so I think that the focus on children and families in the public systems, and systems with a plural, the fact that these kids and families often had some of the same mental health needs but were being served in many different systems it was a real impetus for thinking broadly, thinking about how can we construct services that are going to be helpful. And then right around that same time, NIMH had a tripling of funding for children's mental health. So you got this influx of science about what are effective treatments, what are effective approaches, how can we then infuse that into these systems. And so I think a lot of the sort of zeitgeist for where we are now came from those two directions. And what's happened since then is that we've gotten even more broad in our thinking about healthcare and the way in which the systems, including healthcare, are important when it comes to being able to provide a platform for children and paying attention to the science and the scientific evidence. So it's been an influx of different things.
Wow. You know, it's so interesting what you're talking about. Is for a time I was the co-director of evidence-based practice initiatives in New York State for adult services, and at that particular time, the big issue was, look, here you have research on one end, and you had practice on the other, what people are actually doing, and that was very true in adult service, particularly for people with serious mental illness, and the gap was like tremendous. You know, it's like it seemed that research was having very little influence on what was actually taking place and being offered. And then that sort of was a catalyst for so much discussion around, well, that doesn't make any sense, right? Is that we need to figure out how we can bring what we learned from research and bring it into practice. And is that the case? I would imagine this is sort of like the case in children's services,
for sure,
you know, as well.
Yeah, for sure. It's still a big problem. You know, it's not as though that problem has been solved at all. So from the research standpoint, there was, as I mentioned before, tripling of funding and a lot of focus on efficacy studies. So how do you control all the conditions and get an effective treatment identified? Then there was more of a move toward effectiveness, which is doing these same studies but in the real world.
Doing it in the real world, okay.
And that was all well and good. That was a good movement in the right direction. But there was still this huge gap between what the effectiveness studies were finding and what was actually happening. And in fact, there's been there's a pretty noteworthy finding that you hear about a lot about the 17-year gap, which is 17 years from the time somebody has an idea and does the study to the time it's actually implemented. So the whole idea of implementation science is sort of the newest kid on the block. It's been around now for 10, 15 years, but it's focused specifically on that issue you identified, which is taking research evidence and now how do we actually get it used and applied and used well so that you can get the outcomes. And that's sort of where we are right now, and still a big problem.
Yeah, because I'm just thinking of some of the folks who are listening in. You know, they're clinicians. Some of them are clinicians. They're actually going to be seeing kids today, later on in the afternoon. And they've been getting the message. Like, you know, we really are now entering this phase where it isn't just anything you do is okay. You know, whatever your particular style of intervention, but that your decisions and your selection of approaches with any particular kid, whatever the problem is, ought to be based on what research suggests. These are the kinds of things that you can do that is likely to give you better outcomes. And what do you think some of the biggest struggles are for practitioners, you know, being able to bring in some of that knowledge and actually use it on a day-to-day basis?
Well, I think part of it is that the research findings are typically not presented or packaged in a practical way so that clinicians can easily use it. So that's a big problem. There aren't the kinds of toolkits, specific strategies, specific approaches. So you just hear evidence-based practice. Well, what does that mean? So part of it is that we haven't done a good enough job in terms of getting the research in a way that it can be used. Part of it is that the training typically, for most clinicians, doesn't include a lot of the evidence-based practices. You're sort of taught a lot of things that are valuable, but not necessarily these more specific techniques. So that's another problem. The other is that the treatments themselves or the practices are often so darn complicated.
Oh, are they?
You know,
Okay.
that it's really difficult to get it under your belt, especially if you're seeing kids that have lots of different problems, not just the one for which you may want to be trained. And so I think it's a composite of a lot of different issues that are coming about.
Okay. So really there are significant challenges really to try to close that gap with kids. And where do you think things are going? Do you get a sense that we will have more supports, more practical kinds of guidance? You mentioned also that the complexity of some of these interventions somehow just kind of may overwhelm the person's capacity, right, to actually implement that. Is that something that is likely to sort of change as we move forward, or are folks paying attention to that to try to figure out ways that are going to be much more accessible and less demands on the workforce? Do you have a sense of where that might be going?
Yeah, I think there are three things that are happening that bode well for this problem.
Good. So there's good news.
There's good news. Yeah, there's good news. There's lots of good news, really. One is that the treatment developers of some of the more effective approaches, whether it's a parenting approach, a preventive approach in schools, or a specific treatment, they're doing a better job in creating the toolkits and creating training institutes where you can actually say, I need to learn this, I can go get trained in this and get the support I need to actually carry it out. So that's one thing. Another is that there's been a approach that has come out of UCLA that we're using in New York through the Office of Mental Health, through what's called the Evidence-Based Treatment Dissemination Center. And it's basically distilling down all of the 700 plus randomized trials for specifically psychosocial treatments for kids, distilling those down into some core elements. What are the common factors? What are the common techniques that cut across all of these very well done studies? And can we then train and support clinicians to learn these core techniques that cut across all the different problem areas? And it's such a smart approach. It's called PracticeWise, and it's I think a very useful tool that does require training and it requires support, et cetera. But it's something that we've done in New York, and I think I know because we've looked at the data, to very good effect. So that's another approach, and it's very different from, we're going to learn this evidence-based practice, this one, this one, this one.
Right. So you're saying across so many of these different programs and different approaches and interventions, there are some common elements that we can extract from that that really cut across. So if someone is, if you have a caseload of 40 or 50 kids, and you have some kids with attentional problems, other kids with conduct problems, other kids with depression or anxiety or trauma-related sorts of things, it's kind of an overwhelming situation for any practitioner. Like, how many different approaches do I need to have under my belt in order to be able to address maybe 5 to 10 different clinical situations, not to speak of the unique context of each of those individual kids and families, that type of thing. So the notion of extracting some of those common elements, so that is, if you learn those common elements, right, those core kind of like competencies, then you're in a better position to kind of apply that really across the board. That's sort of like where the field is kind of moving towards.
That is where the field's moving towards, and I think it's a really good movement because it's smart, it's efficient, it's taking advantage of the knowledge base, but then packaging it in a way that can be more readily used with a resource that, so that you can actually say, if I have a 14-year-old Latino girl with depression who's having problems in school, what would be some of the evidence-based practices I might be able to use that will be helpful for this particular situation?
So it's an interesting way of looking at it, because practitioners, they think in terms of an N of 1. They don't think in terms of the aggregate, right? So, if I have a kid who's again 14 years old, Latino or whatever the demographic might be, and they're having symptoms of depression, and I'm saying, okay, how should I kind of go about this? Is there anything in the literature that suggests that there are at least some starting points that I should begin with, right? And then let me at least start there.
Yeah.
And that might be true if the person was really primarily dealing with anxiety, or dealing with sort of acting out kinds of things, or both, or a combination of things.
Yeah.
So this notion of trying to simplify it really for practitioners, and so that you have it's accessible to you. And you mentioned the term practice-wise, which is particular kind of a resource, actually.
That's the resource that you can subscribe to. The training is called the MAP training, Managing and Adapting Practices. Came originally out of the MacArthur Foundation Youth Mental Health Network. Bruce Chorpita, John Weiss, and a group of us were working on something like this. And Bruce in particular, Bruce Chorpita, has now developed this managing and adapting practice. And so we're using it now in New York. A lot of other states are using it as well. And to me, it's smart, and it provides the support and the skills to sort of cover the waters as much as you can with kids that aren't going to come in with just one problem, or it's going to change. And the literature changes too, and what you should be doing. So the other thing that's the other approach that's happening that's very different from this, but I think is also really bodes very well, is developing ways to collect data on the ground in real time about what you're doing, so that you can see whether or not whatever you're doing as a clinician, you're an experienced clinician, you've used various approaches and they seem to work, but you're not really sure. Systems for actually collecting data about what you're doing, and are you seeing the changes, and if not, what could you do about it? Those kinds of data systems are a different way of creating evidence. It's not sort of taking it from what's already in the literature, but it's saying, let's look at what we are doing and see, is it making a difference? If not, how could we change that?
What's really interesting about that is it tends to be viewed as a one-way street, right? Is that the practitioner out there, the arrow goes from like research, and then they're supposed to do something. And what you're suggesting is that an organization or an agency can begin to develop systems so that they actually can be the source of the evidence, right? That they can begin to answer the question, well, how are we doing? That's sort of like a big question. How are we doing with kids who have depression? Are they getting better? Are they sticking in services? Are they engaged? Those sorts of issues. And that would take like a sort of a different way for practitioners and agencies that typically will not see themselves as being the source of data and information to inform not just the work that they do, but can also kind of like inform the larger field as well.
Absolutely. And that comes from the health field. So I mentioned that healthcare as a whole has in some ways shifted the focus of attention on what we're doing when it comes to creating evidence, creating systems, being able to improve the quality of care. And the healthcare field in particular has, I think, been one of the forerunners in terms of creating these data collection systems that will look at what's happening for any particular condition and what is necessary in order to identify changes that represent an improvement in quality. So, there's a lot that we can learn from that, and many agencies are trying to do so by building in some systems. And you can superimpose on that a particular evidence-based practice. But you don't have to if you're looking in real time about what's happening, what are you doing, and you're measuring it well. It's really more about measurement and collection of verifiable, valid, reliable data that's usable. And so I think there's a broadening of how we do that now.
Okay. Yeah, I can see that being like sort of this merger where we don't separate the research world from the practice world, which I think there's like a fairly big distance at times.
Exactly.
In both it's true in the adult services, as well. And I want to ask you a little bit about this issue of involving families in care and treatment. And I've been involved in a project where I would go to many child-serving clinics. And in some cases, kids are being seen with their caregiver, on a regular basis. The unit of treatment is considered the caregivers and the child.
Yeah.
Other times it's caregivers just drops the kid off and picks the kid back up. And maybe there might be some communication with the family at some point, or bringing the family in occasionally. But, you know, I see such variation in the perspective, to the degree to which caregiver involvement is like a very important part of the clinical treatment process. Yeah. And I'm wondering if you have thoughts about that. Does the research sort of suggest, well, you know, it doesn't really matter that much, or it's really critical, depending on the clinical problem? Any thoughts on that? Because that is an issue that folks kind of struggle with, and folk may not feel all that prepared. Like, what do I do if families show up?
Yeah.
And all of those, some of those issues. I hear a lot about that, and I'm wondering if you could maybe give some better clarity on where that issue is.
Yeah. I think a lot of people, and I would include myself in this, when I was trained to work with kids, it was because I wanted to work with kids. You know, it's with kids. And the parents were okay, but it was the kids. Right. But I've learned that it doesn't make any sense. You can't decontextualize a child that way, because they're embedded in the family, number one. Number two, the family's perspective on what is happening or what is needed for the child is absolutely critical to helping the child deal with whatever the issues are, and helping the parents do so. And if we are only focusing on a parent-child unit, that's good, but we're not necessarily addressing whatever the parents need, whatever the caregivers need. And so one of the things that drew me to New York originally from NIMH in 2002 was the fact that there was this incredible network of parent advocates in the state that were already way ahead of any place else, saying, we have a perspective, we want to get involved, we want to not only help our children, but help other parents and other parents' children. And we have a perspective that's unique. It's not just, yeah, bring me along and educate me, although that's good, but we can actually do some work on being able to work with other parents, on being able to help figure out where the obstacles are to becoming engaged, to helping spread this. And so the parent partners, the family support specialists, they're sometimes called, I've learned so much from them. I have them on my research team, and it's so valuable, because the parent perspective is one that we just can't take for granted. No matter how good a clinician you are or how good-hearted you are, there's a special, unique perspective that I think we have to pay attention to and can learn from. And it not only helps the kids, it helps other parents, and it helps the whole clinical case management, because that perspective on what the parents need, on what it's going to take in order to help them support the child once they're out of treatment, which will happen, right, is critical. So it's helping to support the parents by paying attention to what they're saying about their child, what they're saying about the system, and what they need. And it's a way to create some more sustainable approaches.
Okay, so great. So really, we're talking about sort of expansion of our concept of the workforce and the team that's involved.
Exactly.
Right? And that's sort of like a new way of thinking about that. And I'm sort of, wondering, when the time we have left, and then we're going to spend the 5 minutes and then have some questions may come in. On one hand, you were kind of saying, well, things could be getting better, right? Like the news is pretty good.
Yeah.
And that somehow we might be able to address the complexity of so many of these different sorts of like interventions, looking at some of the common elements, some of the core competencies and all. Is there anything that worries you about where the future might go? That kind of, tell us a little bit about, maybe from your perspective, how things may not kind of move in the direction you'd like to see. Yeah,
well, there's some real worries. I think the payment issue is one that has not been solved, and I'm not seeing some solutions ready-made for being able to pay. We're talking about parent advocates, for example. There is now the capacity for Medicaid billing for parent advocates, but it's not at the level that would be necessary to actually retain parent advocates in the workforce. That's one problem. value-based payments, value-based purchasing is a great idea theoretically, but how we're going to identify what is the value of a particular practice or treatment hasn't been solved yet. And so I think there are some concerns that the value-based approach is going to either neglect the whole child field because it's being driven more on the adult side, or it's not going to take into account, for example, we know so much scientifically about prevention, about how to intervene early, about how to get children on a good track early on, or to intervene so that we can put them on a better trajectory.